thank you all so much for being here. We're really grateful on behalf of Barbara O'Brien, the entire OPQIC team, myself, I'm Trisha Short, and our Ariadne team. We are very grateful to have you here and present, and we are really eager to potentially partner with you and your hospital teams for cohort 3 of TeamBirth implementation. So really quick, before I share my screen and all your boxes go away, please continue to share who might be in the room with you and what hospital you're affiliated with. But I also want to just welcome you for this webinar. By no means does this have to just be a space where you come and listen and we talk at you. If you have questions, we desire this to be very collaborative. And so feel free to come off mute. I welcome interruptions, so you guys can ask questions. Feel free to add them in the chat. But the more you engage with us, honestly, the more we enjoy it. So don't hesitate. And I can assure you, if you have that question, somebody else probably does too. So be brave and bold and feel free to ask. Okay, with that being said, I'm going to go ahead and share my screen and we're going to get things started. So this is our OPQIC TeamBirth kickoff or informational session where we're going to tell you a little bit more about what is TeamBirth, who is Ariadne Labs, and why are you being asked to participate in this collaborative. So this is our session agenda for today. I'm going to tell you a little bit of that information. And then I'm also going to have Barbara O'Brien is going to share some data, why now, why we're starting this and what our goals and our hopes are to achieve by partnering with your facilities. Since I'm in present mode, I will say, Denise and Barbara, I'm going to kind of ignore the chat. So if you see something, alert me. So what is Ariadne Labs? Ariadne Labs is a joint center between Brigham and Women's and Harvard T.H. Chan School of Public Health. It is a healthcare innovation system that was founded by Dr. Atul Gawande. And if you've never heard his name before, that's okay. I hadn't either, honestly, until I started partnering with Ariadne Labs. But you might not know his name, but you might know some of his work. He is the creator and founder of the World Health Organization's Safe Surgical Checklist that is now used all throughout globally. So that's one of its founding pieces, but it's really taking healthcare systems innovations, which are super complex, and finding simplified ways to implement them. So the mission statement of Ariadne's Labs is our vision is for health systems to deliver the best possible care for every patient, everywhere, every time. And so what does that mean? Well, that means much bigger than just the United States, right? So we have many different platforms. I myself work with the Delivery Decisions Initiative, but there's also Safe Surgery, Primary Healthcare, Serious Illness Care, Better Birth, and there are partnerships all throughout the world. So that's a little bit about the background of Ariadne Labs. Again, Delivery Decisions Initiative is the platform that I work on. And our mission statement is a vision and world which every person can choose to grow their family with dignity. This is our team, and you will, over the next months, get to know many of them. Amber Wyseth is our director. I'm one of the clinical implementation specialists. My background is nursing. I was a labor and delivery nurse for 17 years prior to taking on this role 1 year ago with Ariadne Labs. I myself have implemented TeamBirth, so I do know the ins and outs and nitty-gritty details of what that implementation looks like. And I hope to bring that expertise to our partnerships with your facilities to really help and support you through it. You will also see here, I have a box around Yara. She is our research specialist and she leads our design work. Amani, she's our project coordinator and she leads all things IRB and Reliance. And then Lynn Elsher, and she does all of our data collection, analysis, and presentations. So these are team members that you'll get to know really well over the next couple of months. But to pause, why are we talking about this? What is going on currently in our nation that really makes us pivot our work to focus on this? And this is why right here. US women have the highest rate of maternal mortality among industrialized high-income countries, and it continues to rise. Black women experience 3 to 4 times higher maternal morbidity and mortality than their white counterpart. And often, whenever they do root cause analyses of what the breakdown was for in these scenarios, it really roots back to a failure of communication and teamwork. 80 to 90% of these sentinel events that reported to Joint Commission have a root cause in communication and teamwork. Therefore, we have decided at Ariadne Labs that this is what we want to try to tackle, but it's hard. It's a complicated situation. And so we've created a structure and the TeamBirth model of care where we really elevate the role of the patient, the nurse, the provider to work together in conjunction for shared decision-making. So let's talk about what TeamBirth is. It's a care process innovation that involves a series of team huddles. It's going to be different for every patient as to the number of huddles. And I want to speak to that really loud and clear because there was some miscommunication or misinformation shared back from last year, October of 2021, when we first started our partnership in Oklahoma. It does not mean that every patient has to have X number of huddles. If you're a multip that walks through the door 8 centimeters, you might have 1 huddle. If you're a primip that's closed, thick, and high, and you have, 24 hours of cervical ripening before we really even get into an active trial of labor, you might have 8 huddles. So it's not about the quantity, but it's really about coming together and having a safe space for shared decision-making. For patients, this really invites them into the conversation and it provides a structure for them to easily understand and know what to expect and anticipate. It provides a platform when they have concerns or questions, fears, or a symptom, they can speak up, be heard, and the clinical team react appropriately. And for clinicians, it really encourages all conversations to be held with the patient. So we're providing very transparent healthcare that's visible to them, and that patients really walk away from their birth experience as an active participant and member so that we are doing things with them and not to them. How do we do this? So this is a little demonstration of how we achieve that. So through structured team huddles, where we have a structure of what is discussed each time, every time, and communication, closed loop communication, that we anchor that information on a shared planning board. That's how we implement this structure to promote better childbirth outcomes. And we do have data to back that up. So if you are interested and curious about the data, don't worry, we will share some of that with you here momentarily. So thinking about what are the design principles, teamwork and simplicity are the 2 design principles for TeamBirth. Because if clinicians, if we're asking to change anything in healthcare, it's always messy, it's always challenging. And I myself can say that I often was maybe a resistor and unsure, skeptical. So it has to be simple in order for us to feasibly be able to achieve it. And it has to be rooted in teamwork so that we all hold each other accountable and we are able to put it into practice. There are 4 core behaviors of TeamBirth. 1 is promoting each member of the team. Why do we do this? Because it promotes psychological safety. Just very much like the World Health Organization safety surgical checklist, we identify who's in the room. The reason we do that is because research shows that if you are identified and your name is spoken, you are more likely to speak up if you have a concern. Same for our patients, but in this case, our patients are the team captains. So we care very much about their goals, their preferences in labor, their fears, perhaps maybe even some misunderstandings and what their understanding and education knowledge depth is rooted in, so that we can all speak to it, share realistic expectations, and have aligned goals and outcomes. So 1 is just promoting the team. Who's on your team? 2 is eliciting the preferences. So really understanding what their goals for birth look like. 3 is distinguishing a plan of care for both mom, baby, and labor progress. Sometimes they get so convoluted, it's best to disentangle what we're doing for the mom, everything outside of the uterus and cervix. So it typically goes back to her comfort, her environment, her wishes. And then the baby, what are we doing for monitoring? Is it continuous? Is it intermittent? Do we have clear fluid or meconium stained fluid? Those are relevant pieces of information that impact the care for that baby. And then labor progress. What are we doing to help you make cervical change? Maybe it's you're 6 centimeters in spontaneous labor and we're not going to do a thing. We're going to wait and watch. Maybe it's you're 40 and 4 and now it's time for an induction and we're going to start with cervical ripening, side attack, Pitocin, rupture of membranes. That's what we're doing to help you make cervical change. And then 4, and honestly, from the patient's perspectives, what I learned and in my own implementation experience is probably the most important to them is setting clear expectations of when the team's going to come back together. It doesn't have to be a time. You don't have to say, it's 2:45 right now and we just checked your cervix and we're coming back in 2 hours at 4:45. It could be a time range. It could even be a symptom. Maybe now your patient is 5 to 6 centimeters and you're not going to huddle again until she starts to feel pressure. It could be a symptom. But really setting clear expectations for when we anticipate the team to come back together. All right. So this is the TeamBirth core components: huddles and the shared planning board. The huddles are the conversation that we have. It does not have to necessarily mean that the provider is present in person at the patient's bedside. It can be achieved over speakerphone. And so that way you would normally call to give a provider an update out at the nurse's station or in the hallway. You can still do that, but take it to the bedside and allow the patient, 1, to hear what you're reporting, and 2, ask questions if they have any concerns or if they have any questions. And then once that conversation is completed, you take that communication and anchor it onto the shared planning board, because that then is closed loop communication. Everybody's aligned on expectations and they know what the next plan is in the plan of care. So let's talk about these TeamBirth huddles: who, what, when, and why. Who has to be present in order for it to be considered a TeamBirth huddle? At a minimum, it must include the patient, the birthing person, the provider, and the nurse. So the provider can be a midwife or whomever is the appropriate family practice, OBGYN, whoever's most appropriate at your facility, the labor and delivery nurse, and the patient. Those 3 members must be present. If it's just the nurse and patient, not a TeamBirth huddle. It has to have the full clinical care team. What are you going to discuss? Well, each time it might vary what your discussion is. If you're at admission versus if you're now 6 centimeters and you're calling the provider for labor or for delivery, those discussions will change. But we always need to be attentive to patients' preferences, the plan of care, so the patient understands fully what to anticipate and expect. And then again, the next time you're coming back together. And the big question of when: how frequently are we going to have to huddle with our teams? Again, it's going to vary for every patient every time. There's not a consistent number for any one particular person, but these huddles should occur from admission all the way to discharge, whether you're in labor and delivery, an LDRP, or a labor and delivery postpartum. Huddles should occur so that they're receiving the same style of communication and teamwork from admission to discharge. So at a minimum, TeamBirth huddles should occur on admission. Anytime there's a change in the plan of care. So maybe that's because I'm the bedside nurse. We had an induction of labor. My patient was on Pitocin. There was some event that occurred. We started having recurrent late variables. I turned the Pitocin off. That's a change in the plan of care. I'm now going to call my provider at the bedside, where I would normally have always called at the nurse's station to notify. I'm now going to call at the bedside, explain what I'm seeing, the interventions I've completed, and discuss what the plan is from the provider's goal for next steps. It's different every time, but at a minimum, on admission, change in plan of care, or at the request of any team member. So if the patient has something very urgently that's changing, they have questions, fears, concerns, and they need to talk to the provider, we should allow that to occur. And then why? Because we're really giving team members the opportunity to participate in shared decision making. So this is the shared planning board. I have here both an example of labor and delivery, which is on the left, and a postpartum planning board that's on the right. However, we do recognize that many teams may be an LDRP model, and we have those examples as well. But every time we do want to make sure that this is rooted in simplicity. Feedback from patients have been that the more busy the board, the more clinical the space and the less it is for them. So we want it to be rooted in simplicity. We want to have a space to identify the team preferences, the plan of care for mom baby labor progress on the labor side, and the plan of care for mom and baby on the postpartum side, and then the time for the next anticipated huddle. In postpartum, it's a bit different because now you have a pediatric team and an obstetrical team. So you have to identify what time or when you anticipate the teams to come back together. This is an example of UMass Memorial's Labor and Delivery Planning Board, and they're located in right outside of Boston, Massachusetts. They did leave a notes section on theirs, but every team will go through a design phase with us, and we want your teams to incorporate and include the required logos or anything that your marketing team says you must have. Some teams have hourly rounding because that is an institutional standard, and we are happy to accommodate all of those. But this will be a very collaborative time for us to work together and to design and create your labor and delivery and postpartum shared planning boards. Okay, that's the core. These are the add-on. These are the discussion and support guides. So these are flexible components that we strongly encourage that you implement and roll out all together. They are written fairly small, but don't worry, they're on the OPQIC website, so you will be able to find access to them. The one on the left is the admission discussion guide. The one in the middle is the labor support guide, and the one on the far right is the assisted delivery discussion guide. These tools, although they are written in patient-facing language, so that might be unfamiliar, they are all SMFM and ACOG guidelines for when we should proceed to a C-section, when we should admit for labor. It has definitions on there, but it really allows the patient to ask the questions and the team to come together to collaborate for the best shared decision-making for that patient in that moment. We can share these with you, but I just wanted to give you a high-level introduction. As we go into more further down in our partnership and collaboration, we'll get into these tools a little bit more in detail. But these are the kind of outcomes that we anticipate to see. So by implementing the core, which is just the huddles and the shared planning board, what we see through thousands of patient surveying is elevation in patient dignity and their experience metrics and their different validated tools that we use, MADAM, MORI, trust scales. We see an elevation in their experience, and I'll share some of that data with you soon. It mitigates our implicit bias because it's creating a structure so that we deliver the same communication style. We are going through the same core behaviors every time for every patient. And by doing so, what we have seen as a really kind of a happy side effect, it does improve unit culture because there's a little bit more accountability and respect among the clinical team. I don't know about you, but I do recall that whenever I was a brand new nurse, calling a provider at 3 a.m. was a bit more intimidating than calling the provider at 3 p.m. on my orientation. Well, whenever we put ourselves at the feet of the patients that we're serving and we're collaborating together, some of that tension is automatically removed, and we have higher level of accountability and support for one another, expectations, because we're showing up our best self in front of our patients. Now, the add-on decisions, those shared decision-making tools that I just showed you in the previous, what we do see from incorporation of those tools in your implementation is a reduction in your NTSV scores and decrease in your severe maternal morbidity and mortality. So we look at things like PCO6, which is unexpected newborn complications. We look at hypertension. We look at postpartum hemorrhage, but we see a reduction in those. Okay, I said I was going to get to the TeamBirth research. So I'm going to share with you a little bit of the journey from where we were, where we are, and where we're headed. So how did this whole thing come to be? Well, I saved this slide and I kept it in here because just in case you haven't heard or you didn't know, St. Francis Hospital back in 2018 was one of the 4 pilot sites for the TeamBirth trial. So we partnered with Ariadne Labs 2018 to 2019 to implement, and really it was just in its design and test phase. So we were testing the design that was created after all of these working sessions with experts all throughout the United States, ACOG, SMFM representatives, patient, doula, midwives worked together. We created this model of care, and then we tested it in these 4 sites. This was the pilot trial. St. Francis was part of it. And through that is how the partnership with Barbara O'Brien, who was a part of those planning and development and design sessions, that's how this connection with OPQIC came about. What we were testing in that, I love it, Barbara. What we were testing in that first pilot trial was acceptability and feasibility. So could clinicians do it, and did they like it? And what impact did it have on patients? So this is just a really high level snapshot of the feedback that we received. So from the patient's perspective, 97% had the desired role that they wanted in their birthing experience. 98% of patients reported clear communication with providers and ability to share their preferences. And then not only could they share their preferences, but 90% felt that their preferences were honored. So they shared their goals and their preferences made a difference in how that care was delivered to them. Now, surprisingly, this was pre-pandemic, but again, I am a healthcare professional and I know I can be skeptical and resistant to change. Well, we expect that really of all healthcare professionals, and maybe even more so now since the pandemic, where life was changing every hour, literally new policies and procedures from 8 a.m. to 8 p.m. But we did interview, collect data, and do focus groups with clinicians. So some very eager and quick to change, and those that were also very resistant. And this is the data that we got back. 93% of clinicians felt that TeamBirth improved care for their patients because it had better communication, teamwork, and the opportunity for shared decision-making. 90% of clinicians said they would recommend it to other L&D units. And 84 said that it did help clarify non-urgent C-section decision-making. And all of those results have been now published. So they are available for you. And I think, Barbara, Denise, correct me if I'm wrong, but I think that are also on your resource page on the OPQIC website. So you can find any of these oh, go ahead.
They are on our website, and I bet Denise is looking up the link right now because she's so good already.
That's awesome. Thank you, Denise. I appreciate that. But you can also Google them and find them. There's a TeamBirth design, primary outcomes, and implementation. And so all 3 of those manuscripts have been published, and you can read them if you're interested. All right, now let's look at some of our data. I could seriously spend almost the full 90 minutes talking about data, because even though I was never what you would call like a data guru or data junkie, I have become one. And really it's because it's once we measure something, that's really when we can start to impact and have the change. And so it's really encouraging to see. So first, let me orient you to this slide. This is a slide that was, it's unpublished data. It will be published, but it's just a matter of probably sometime early spring of 2023. But it's been analyzed and unpublished. It was through the data collection of 4 specific hospitals, 2 in the state of Oklahoma and 2 in Massachusetts. All of the data has been aggregated and de-identified, and this is some of the outcomes that we have seen. So looking at the left to the right, you're going to see no, yes. So in the bottom, you see Hispanic, no huddle, yes huddle. Alaskan Native American Indian, no huddle, yes huddle. Asian, no huddle, yes huddle. And what you see in these colors, this high, moderate, low, very low, so dark blue being really good and that white being less desirable, are the MADAM scores. MADAM stands for Mother's Autonomy and Decision Making. It's a validated tool out of the Birth Center by Dr. Saraswati Vedam. It is used globally, so not just in the United States. It is validated in the United States, but also globally. And it really asks questions about, were you given options? Were you explained the pros and cons of those options? Were you allowed time to make a decision? Were you respected for your decision? So those are the types of questions that were asked. And what we see is that whenever patients have the opportunity of team birth huddles, their autonomy scores rise. Most notably, and definitely what we will continue to collect data around, we still are, but especially for Black, African American, multiracial, we see a pretty significant increase in their high autonomy scores whenever they have experienced a team birth huddle. Now, these denominators for some groups are still so low, we need to continue to collect data, which we are continuing to do so, but it's encouraging at this point to see that big of an increase. All right, so that's some of our data. And then one of our hypotheses that we're measuring right now in our collaboration with OPQIC is the pandemic has impacted us in a multitude of ways, but really what we are hypothesizing is that trust in the healthcare system has been shaken. And so we're trying to understand if teams or if patients participate in team birth, does that increase trust? And so again, we're using a validated trust scale. It's the HCRTS-R, and these are the options, the questions that they ask. Discuss options and choices before healthcare decisions were made, told me the complete truth about my health-related problems, so they felt like care was transparent, that we weren't sugarcoating anything, felt comfortable talking about my personal issues, committed to providing best care possible. So what we see here, these are the questions that are asked. The blue is for patients that have experienced team birth. The orange is for patients that report no, they did not receive team birth. And we see an increase in every metric across the board whenever they experience team birth. So this is something that we have only just started collecting through cohort 1 data. And cohort 2 is now also starting to, and then there's going to be an opportunity and option for you as a participant in cohort 3 to engage in this as well. Patient data collection is absolutely necessary, whether you do it for research or you do it for quality. We'll get into a little bit more of those details here in just a little bit, but right now, I'm going to go ahead and hand it over to Barbara O'Brien to share with us why this is so important now in our time.
Thanks, Tricia, and I just want to thank everyone for joining us today. It is very exciting to see those data. In fact, I can recall, as you all may know, I was the A1 representative on the Council on Patient Safety and Women's Healthcare, and we had our last meeting that we were able to have right before the pandemic. We were talking about trust and how this was a critical issue that we needed to address. And it was, how do we do this? And it's very exciting to see these data and how team birth, which is a simple solution, can increase trust between the healthcare team and the patient. So if that's not enough to say why now, let's look at some more data. And Tricia, if you can go to the next slide. So you all are probably familiar with this when we look at C-section rates, and this is not the total goal of team birth, but we do see a reduction in these rates, particularly the NTSV rate when we look at hospitals that do team birth. Tricia mentioned the accountability that comes about very naturally because of the transparency and preferences that are honored. and what she said of doing things with you instead of to you. So this is where we stand now in 2020, looking at particularly the one that we can influence the most. If we reduce these NTSV C-sections, that will bring down the overall C-section rate. We're the 20th highest, so this is something that we do better than some states, but currently about 1/4 of Oklahoma nulliparous term singleton vertex C-sections are done, and that's really for those who probably should be able to, most of them should be able to deliver vaginally. So looking at the next slide, we also see that these rates vary tenfold among U.S. hospitals. And what this really reflects, C-sections are the most common surgery in the United States, and the second one is hysterectomies. So when we look at both of those top two, it's among the population that we serve. And when we look at how do we reduce C-section rates, when we improve the data collection and measure this, we look at it and pay attention to it. And we know that CMS is likely going to be starting to, in fact, I think they are, going to be publishing the NTSV C-section rates on their Hospital Compare website. Currently, they do report, like they will be reporting if it's 30 or above, they'll give a rate, or if it's below, it'll just say, check, you meet that. But still 30% is pretty high when you think 1/3 of those women are having C-sections. But we did see one of these 4 pilot hospitals saw a reduction in their NTSV C-section rate of 12 percentage points. So that's not 12%, that is 12 percentage points, just by being transparent with communications and decisions and bringing everyone at the bedside to make these decisions. We know the biggest driver for whether someone gets a C-section, those NTSV C-section rates particularly, is which hospital they choose to give birth in. So which doors you walk through when you are going in for labor is the biggest determinant of how likely you are for those first-time low-risk moms to have a C-section. Does the culture value and the providers and the nursing care team and everyone there value the vaginal delivery over C-sections, or are they treated equally? Or sometimes C-sections are even, in some hospitals, much higher even than 50%. So using these decisions, making this very transparent, can help with that C-section rate. And the other thing that we can also do, the last bullet, using those supportive birth professionals such as doulas, because this is something that as a labor nurse we used to be able to do this supportive care, and that's kind of been is not as offered as much as it used to be. So doing that can provide that continuous one-to-one support can certainly help. So looking at the next slide, we also see that our severe maternal morbidity rate has decreased in Oklahoma with the implementation of the hypertension and the hemorrhage bundles. And this is, using TeamBirth can help us support reducing that NTSV C-section rate. But what it also does is help with the implementation of that respectful care bundle and ensuring that patients are respected, they're treated with dignity, and they are part of the decision making is a big piece of that, and being transparent with what's happening. I'll mention today I was at Walgreens picking up a prescription, and while I was waiting, I could hear the Walgreens staff team talking about people at the drive-through. So I'm standing there and I hear their team, they're like, why don't people have their stuff ready when they pull up? I mean, what does that lady think that we're doing this? And yeah, they say things like, you're so mean. Well, how am I supposed to do my job if you don't have your stuff ready? And they were doing all this, and I was like, ooh, that's pretty disrespectful. But how many times do we talk in the nurses' lounge and talk about people? And sometimes you might need to vent. I give you that. But do we label people, and are we treating people with respect? Are we talking about people jokingly behind their backs? And I think putting everything out there and being transparent can reduce this, and also then is our way of implementing that severe maternal morbidity bundle, and hopefully, the respectful care bundle, and hopefully even reducing the severe maternal morbidity rate even more. By the way, I did say, I just wanted to let you know that I have heard everything your team was saying about the people that are driving through the drive-through. So I had to let them know. Anyway, I just thought about that. That was not very respectful, and we all could hear it. So looking at our next slide, we see that our maternal mortality rates we're going in the wrong direction. We did see them start to drop beginning in 2018, 2019. I'm afraid to say they're probably going to increase again because of COVID. So it is hard to tease out everything that's going on. But we do know that having these open communications can improve the morbidity rates of our patients, and ultimately mortality also, for those that are preventable. So let's move to our next slide. And you all know this, I'm sure. This is the public health measure with the highest disparity. And in Oklahoma, we have about 2 to 3 times rate higher mortality for Black women and people of color than white women. So why is that? And I don't know if we really know everything that happens here and what's going into this, but we need to work to try to improve that. If we are providing the best for those who need it the most, then we're providing the best for everyone. So it's not taking away from someone to give to another. It's providing that best care we can to all of our patients, and using this standardized communication model and shared decision making is a way that we can work towards improving this disparity. Looking at our next slide, I want to turn it over to Sarah, who is going to talk about some voices from Oklahoma patients.
Thanks, Barbara. Hi, everybody. I know that I've met some of you, but if I haven't met you, I'll just give you a quick, I'll just introduce myself quickly. I am a patient partner who works with OPQIC, and part of my job is to identify other women or birthing people in Oklahoma who've had a birthing experience, who can join us in a patient partner network that we've created and help inform the work that we're doing in quality improvement across the state. So a couple of the patient partners that we've worked with over the years shared these comments to us as we began our journey on TeamBirth. I'll go ahead and just read them to you. The first one says, including me and my family in communication during labor would have eliminated so many questions that I still have about what the team did or didn't do to help me. And the second one says, I would have confidence to ask for more testing, and maybe the multiple doctors working on my case would have worked more collaboratively with me and together to get an effective plan in place. We've talked with our patient partner network over the last year and a half or two about TeamBirth and how it would have impacted their birth experience. Beyond what was shared with you guys here in these 2 comments, I can just say that every patient partner that works with us has expressed the desire they have to see TeamBirth implemented across the state of Oklahoma, because they know that it would have changed their experience dramatically. Even if it hadn't changed their outcomes, even if they had still experienced some sort of complication or maternal morbidity, they would have left feeling more empowered, and they would have left feeling heard in their birth experience, and they would have left without as many questions. And those questions can often haunt a birthing person a long time after their birth experience. So we want to share that with you guys as inspiration. We've got a lot more input from them as well, and we would love to share anything we can with your teams along the way to help inspire them. We truly believe this is the best thing that we can do for our birthing people in Oklahoma, to help them have an empowered birth experience.
And I'll just share, thanks Sarah so much. One thing, we just actually got off a coaching call, which is something we have monthly with the teams. I think it was week before last. And, just having the ability for the patients to hear what is happening is so meaningful. Call the doctor. And being able to hear Trisha, like what she was talking about at one of the scenarios earlier. Hey, my patient is having some lates, and I turned off the pit and blah, blah, blah. This is what I'm doing. Then they know what's happening. It's very transparent. And the other thing that we've seen is this really elevates the nurses in the patient's minds. People are always like, what do you do? So much of the work that we do as nurses, the patient is invisible, and the patients don't really know what's happening because a lot of it's happening outside of the room. And so this makes it visible, and it gives a lot more respect to the nurses and the team, and provides this easy mechanism for advocating for your patients and talking about making decisions together. So looking at the next slide, that is why we are in this 3-year collaborative agreement with Ariadne Labs and OPQIC, and it's through the Oklahoma State Department of Health, through State Maternal Health Innovation Program grant funding that they have received from the Maternal and Child Health Bureau, Health Resources and Services Administration. So this is these are some federal funds from the Department of Health and Human Services. So we thank them for their partnership and supporting this work. We are the first state to implement TeamBirth statewide. So we hope you all will be one of our hospitals. And I'm going to turn it back over to Trisha.
Perfect. Thank you, Barbara. Definitely the first. Oklahoma is the first, which I am so proud of because I'm an Oklahoma native, born and raised. But now certainly not the last. There's many more to join these collaboratives, and I'll share some of that information with you soon. But first, let's talk about this. What will TeamBirth look like for you at your hospitals? We're not going to get into the weeds, so to speak. We're going to still say high level, but this kind of gives you an overview, a snapshot of what we will be doing over the next 6 months and beyond. We will have 90-minute monthly learning sessions. There will be 2 opportunities. So if you're more of a morning at 9 a.m. or an afternoon at 1:30 p.m., we're going to try to make it as conducive and accommodating to your schedule as possible. And in those learning sessions, again, it's 90 minutes. That's where we're going to collaborate, partner, and work with you for every step of the way through the journey. So we'll talk about board design and adaptations. We'll go through far more training scenarios. We will really talk through an implementation pathway, and there's a science to it and what that looks like. So socializing, finding those early adopters, asking them to be champions. You need them for both your provider and your nurses, doing small scale testing, training your larger group of staff and providers, and then getting to your launch event. There's many steps along the way, but my promise to you is that you will have our partnership and our support through every step along that journey. So those are our monthly 90-minute learning sessions. Someone from your team should attend every month. And then we will also have monthly coaching calls. Those will be 45 minutes with each of your teams. And that's where we're going to individually support you and really adapt TeamBirth to your circumstances at your site, knowing that there's different nuances among every team. And so that's where we'll partner with you. We do ask you to include anybody that'll be working on TeamBirth with you to join those calls. So again, it's another collaborative effort. And this is kind of our timeline. So right now we're in September, which is kind of hard for me to still believe. But this is where we really want to start identifying and recruiting our hospital partnerships. So I know that this is an informational session for you to come and learn more about it. Our hope is that you'll, if you're interested, ask the right questions to really identify how you can be a part of the cohort 3 recruitment. You're going to want to start thinking about when you build an implementation team, they look different. Are you the largest delivering site in the state of Oklahoma? You might have more resources. If you're a smaller LDRP that does, 600 to 800 deliveries annually, you might have fewer resources. But again, that's okay. We adapt and support to meet your individual site needs. And then there is an opportunity for research. So much that I mentioned earlier about that data collection and how we are going through analysis right now and writing a manuscript that'll be published early spring of 2023. After this 3-year partnership with OPQIC, we will aggregate and de-identify all of the data, but aggregate it together and report out in a manuscript, a publication. So your site in cohort 3 will have the option to decide. Cohort 1 and cohort 2 are participating with research. Cohort 3 has the option to participate with research or just participate as quality improvement. The difference is pretty minimal. Patient surveying, you cannot change that which you do not measure. So patient surveying is absolutely critical, and that can either be done through research or it can be done through quality improvement. If you decided you would like to be on the research side, we have an IRB process and a reliance process where your institution will seed review to the Harvard IRB at Ariadne Labs. And it's a process, again, if you're thinking, I have no idea what any of that means, it's full gibberish, I don't speak that language. I was in the exact same situation as you, so don't feel alarmed. But it's something, honestly, probably within your compliance department that we would work with together to determine if it's an IRB, an IAA, or an IAA agreement. It's different for each institution, but you would not need to necessarily be involved in that process as a clinician. So that's something that I would want you guys to really think about. If you have questions around that, don't hesitate to ask. This is what the rest of our timeline kind of looks like. In November, we'll go through the board design. You'll want to engage your marketing team because there's probably different logos or different things in your institution that are required that we'll be sure to include. In December, we're going to start talking about that patient surveying. Every team will do it, whether it's for research or for quality improvement. Every team will participate in patient surveying so you understand the impact that TeamBirth is having on your patient population. In January, February, that's when we're going to recruit those champions that I talked about. We're going to start doing some small scale testing. We're going to then train staff and providers with an anticipated launch date of March. That might sound overwhelming. We want to be really transparent about our outline and timeline. And our promise to you is that we will partner with you in this work. So our hope is it never feels like a huge burden or very overwhelming, because we're going to be allies with you in this work and support you however we can. So taking a step back and looking at the big picture, where is TeamBirth? What is the scale, the impact it's having, and both nationally and globally? So I wanted to share with you guys kind of where we are right now. As of 2022, this is actually outdated material. We will have been implemented in 77 hospitals across the United States through partnerships like OPQIC and other various sources. These are a list of different hospitals that are currently implementing in different states. Michigan is partnering with us similarly through the OPQIC as a perinatal collaborative to launch statewide. Illinois, through their perinatal collaborative, is partnering with us to get funding right now to launch statewide. So we have many states. Massachusetts is right now recruiting a 12 hospital collaborative through their perinatal partnership. So this is kind of like, it's growing so big and so fast, and you get to be a part of that movement. And so really the question is, will you join us? And we hope that you will. And again, this is a great time, honestly, for us to pause and have some Q&A if you guys have any questions. This is a pictures from cohort 1, just a few, 4 of the 9 hospitals in cohort 1 from their launch events. And now we continue to meet with them monthly. We're doing coaching call support to really understand post-implementation, the challenges that arise, because there are challenges, but we work through them and partner with them. So before we go on to next steps, I would love to just pause for a brief moment, and I would encourage anybody to come off mute. Feel free to ask questions or get clarity on anything that you might have.
Hi, this is Tracy from Norman. I had a question about the huddles, like on admission. Does that include, like, if somebody comes in with like a plan and they're, our patients come in at 6:30 with they've already talked to the physician at the office that we're going to do induction with Pitocin and all that. Are we supposed to be calling them? Are we supposed to be having a huddle at 6:30 when they arrive? I mean, how's that supposed to work?
Okay, so Tracy, that is a fabulous question, and I'm so grateful that you asked. So we try not to be too prescriptive on the timeframes associated, because we know that each team does their own admission process is a little bit different. If your patient comes in fully aware of what is going to occur in the plan of care, a 6:30 huddle is not necessary. You can wait for either when that patient or when that provider rounds to come see them that morning to do their admission huddle. But there needs to be some kind of formal kickoff from, you've arrived, here's all the things that we're going to do, and we're going to check in with your provider. At some institutions, that means within the first hour. At some other institutions, it means it's flexible, especially when they come in for inductions. Now, if your patients come in and say, Cytotec, what? I don't know what that is. Then you, yes, need to have an admission huddle very quickly, because the plan of care has not been discussed in a way that they fully comprehend and understand. And as a nurse, that would be outside of our scope of practice to explain all of those risks and benefits. So that, as a nurse, you would identify as a need for a patient huddle so that they have clarity in the plan of care. Did that answer your question?
It did. Thank you.
Okay, perfect. Yeah, that was a great question. Keep coming. Ask more. We want to hear all the questions.
And I want to mention for the Norman team, we do have your commitment letter. So I know we're not going to get into next steps yet, but if just to assure you all, we know that you all will be participating in cohort 3, so we're excited about that. And I do see some people from Norman that are on today that work in newborn care and even the NICU. So wanted to mention that. I know, Tricia, do you want to go over the usual steps if they do have a NICU that wants to implement and how we work that?
Yeah, no, absolutely. So team birth and labor and delivery postpartum, we have designed, tested, and now we are implementing to scale. So multiple hospitals, well, really we're close to 77 hospitals and impacting hundreds of thousands of births. Our NICU work is still in that design and test phase. We partnered with a team actually in Oklahoma, Hillcrest Medical Center. They had seen such profound positive impact for patients in labor and delivery and postpartum. And they actually came to us and said, what about the NICU? Could we also do this here? So through a partnership with them, we did create a NICU version of TeamBirth. We've only tested it in one hospital, so therefore we cannot yet spread to scale. But if it's something that you're interested in, we're very happy to partner with your hospital to discuss next steps on that. The other thing I wanted to let you guys know is that TeamBirth is also being now implemented globally. We are partnering with the Royal College of Obstetricians and Gynecologists in the United Kingdom, and we're also working with Ethiopia, Zanzibar, and in Norway with medical company Laerdal Medical. So we are starting to grow. There is a demand even outside of the United States for respectful maternity care, and many are recognizing that TeamBirth provides actionable steps to achieve that. So if you don't have questions yet, think of them, because we really want to help answer and provide any clarity so that you might be willing to join us in our third cohort. There is no dumb question. The only wrong question is the one you don't ask. So please feel like this is a safe space. We want to provide psychological safety too, and you can ask us all the questions. I will go ahead and hand this back over to Barbara to share next steps, and then we'll have another pause point for questions. So keep thinking about it.
Yeah, and I just want to also share, I know when I first heard about TeamBirth, I had listened to Neil Shaw, who was the developer with some other team members at Ariadne Labs. I heard him present, I think it was in 2017, at a presentation at the CDC. And then he came here in 2018 to talk at our OPQIC summit and talked about TeamBirth. But when I first heard him talk about it, it was literally a light bulb moment of, aha, this is a way that we can solve lots of problems. And I've seen that play out in the implementation of TeamBirth. Looking at these, we talk about these with our teams on their cohort, on their coaching calls, I should say. And it's just so interesting to hear how TeamBirth is kind of magical in how it can address so many issues. And it's such a simple solution. So I wanted to share that with you, and yeah, that's why we're doing it. And we certainly hope that you and other hospitals join in this effort. We have every single hospital in the Tulsa metro area has implemented TeamBirth. So they're all using TeamBirth in Tulsa, and we need to step up our game and get the rest of the state involved. So I'll talk about next steps, and then if there are any questions, we would encourage you to come off mute again. But there is a hospital commitment letter, and you will receive these slides in an email, and we are recording this webinar, so you will have access to the recording and can share that with others who may not have been able to join today. But on our website, there is a link on the TeamBirth page to our commitment letter, where if we need you to get the appropriate signatures, and you can just return it to me, and we will move on from there. Sometimes it takes hospitals a little bit longer to get the appropriate signatures, so that's okay. It doesn't mean that you can't do anything. until you get the commitment letter. You're free to join in on our learning sessions that we've scheduled, and we'll work with you on the commitment letter. So we do need that just to ensure that everyone that it's not just one person at the hospital that says, hey, we want to do TeamBirth, that you have support from your administrative, executive leaders, your unit leaders, and everyone there who needs to support this work. Begin talking about this and sharing the link to this recording and to the slides, and talking about TeamBirth and who could be your team members, who could be those champions that will be the day-to-day leaders on your unit, to really be the cheerleaders and the ones who move this train forward. Who needs to be on your implementation team, that team at the higher level of leadership, who are the decision makers to move this forward. So be thinking of those things, and we are happy to help. If you need us to have a meeting with your OB medical staff, we're free to do that, happy to do that. If you need us to present to other team members, we're happy to meet with them. Just you let us know what we need to do and how we can help you communicate about this opportunity. We have planned our TeamBirth kickoff planning sessions and our learning sessions that will be held 2 times a month. We want team members to attend at least one of them. So coming up will be October 6th at 1:30 and October 7th at 9 o'clock. So the learning sessions are scheduled for the first Thursday at 1:30 and the first Friday of every month at 9 o'clock. And then Denise has put the link here, how to register for those. And we would really ask you to include people, especially that implementation team. Once we start having the coaching calls, we'll start planning those with you all. And those are the ones that we really want a lot of people from your hospital to attend the coaching calls. Anybody can attend these learning sessions that are held monthly also, and please feel free to register. So anything else, Denise or Tricia, feel free to come off mute if you have any other questions.
Okay, this is Tracy again. Got another question. So, like, what people do you recommend or have most places used as they're on their teams? Because should it be more bedside nurses? Should we focus on getting physicians? I mean, what's the makeup that we should make of these?
Tracy, I love your questions. These are great. Thank you so much for coming off mute to ask. So implementation team versus like your bedside nurse champions, there's a difference. The implementation team is going to really be your leadership. Who does that mean for you? We want at least one provider on your implementation team so that if anything does come up and you need a provider backup, it's good to have a provider available and on your implementation team. If you have nurse managers, supervisors, educators that work in maternity, I would strongly encourage they're in a leadership role. So we want them on that implementation team. People on your implementation team are really going to be the ones that show up, understand the content, and move the train forward. They are also going to be the ones that when conflict or challenges arise, that they make the decisions on how to proceed for next steps. And then you're going to have champions. Your champions are going to be more of your bedside clinicians. And also we want you to recruit providers for that as well. But they're going to be the more day-to-day what's going on with the implementation of TeamBirth and less on the operational side, setting up and executing TeamBirth. Does that answer and provide good clarity?
Yes, that helps me a lot.
Okay, great. That's perfect. Sorry, I'm echoing. Any other questions that you guys might have? Okay. ARIA, this is different from the OPQIC website. The OPQIC has a multitude of resources, so that's really where I would encourage you to go. But if you want to have more understanding of really Ariadne Labs, Delivery Decisions Initiative, ARIA also has those tools. They have the implementation toolkit, a bunch of different resources for training staff and providers, scenarios. It's a free website. So all you have to do though is put in your email address to access the website. And it's something that if you're interested or inclined and would like to go and look around or get more information and details, that's an option and an opportunity. So we just wanted to share that. Okay. And then finally, I will answer these two questions. But again, I encourage you, if you have any additional questions, come off mute and ask me. These are questions that some people asked us prior to our informational sessions, both for cohort 1 and cohort 2. And there was a theme, so we thought we'd just go ahead and address them. So is TeamBirth training for labor and delivery only or for the entire maternal child team? TeamBirth is from door to door, admission to discharge, labor and delivery, and postpartum. It will look a little bit different if you're an LDRP model, but not really different in like the concepts and behavior, just different in like the tool visuals of the shared planning board and how you make that transition. So right now, implementation should include all of your nursing staff, anybody that does deliveries. So if that's OBGYNs, family practice, midwives, and your pediatric teams, who rounds on your babies? Do you have nurse practitioners? Is it your neonatologist? Every hospital has a little bit different of a system and a structure, but we want to include them in all of the training and implementation of TeamBirth. And then this one is always asked nationally, not just locally to Oklahoma. But how do we implement TeamBirth if we have resistant providers? I mean, our goal always is for any quality improvement to be a collaborative and multidisciplinary push from both providers and nurses alike. However, maybe you've done other quality improvement where you didn't have that level of support that we desire. That's okay. You still can. I personally, when I was implementing TeamBirth, I had a provider who had been practicing well over 30 years. And he came to me and he said, now here's the deal. It's not that I'm resisting TeamBirth. It's that simply you can't teach an old dog new tricks. So you prompt me and I'll do it, but I probably won't ever initiate it. I appreciated one, him being that transparent, but two, also that vulnerable. Like it's just because I'm kind of set in my ways and it's hard for me to pick it up. Well, this can be the case whether you're working with a 30-year experienced provider or a 3-year resistant provider. It's really just holding them accountable because a lot of this, although it can be nurse-driven and nurse-led, we don't want it to be, but it can be. So that means I'm calling at the bedside and saying, Dr. Smith, I'm putting you on speakerphone to give you an update on your patient in room 6, Sally. Is now a good time for me to do a huddle with you? No, it's not. Could you please call me back? And when do you expect that to be? In 5 minutes, I'm with a patient. Okay, great. I'm going to hang out with my patient and we're going to have that speakerphone huddle. And maybe it's me reporting the symptoms like we just got an epidural, her blood pressure dropped. I gave her the ephedrine. I gave a fluid bolus. We're still down. Baby's still having lates. I had to turn the Pitocin off. We're continuing to watch. Variability is improving. What would you like for me to do for next steps? Again, there it is. Barbara's we're making our care visible to the patient. I remember actually giving that report one time and a patient was like, I had no idea you did that many things in that short period of time. And that's why you flipped me to my left side. Yes. It's like, okay, you're getting now credit in front of the patient's eyes for all the things that you do quietly and silently to really care for them appropriately. And so that is still holding a huddle and bringing in perhaps a very resistant provider. So you can still implement TeamBirth even if you don't have resistant providers, but it does require strong nurses. And I will tell you now, having worked all throughout the United States with hospital teams, this is not lip service. This is genuine sincerity. We work with some of the most incredible nurse leaders and the most resilient nurse leaders that I have found in any other state. So if there's any team of nurses that I know could rise to the challenge, it is our Oklahoma nurses and our Oklahoma leaders. So don't feel too discouraged. You will likely, it's not if, but when you'll bump into that. But we have so many tricks that we can help partner with you in to really overcome those obstacles and hurdles. Okay, so now I gave you some questions. Any other questions that you guys might have? Okay, if not, well,
I just want to add one thing. We've had some hospitals where the doctors are like, I'm going to write an order that my patients can't participate in TeamBirth. Or I don't, we've had some pretty resistant providers. And, we will work with you on that. And really, they come around and they really do it a lot because they hear their patients like it. And they want to be, we all want to do things that help our patients. And by providing this respectful care and ensuring this shared decision making, it really does help them to see that, yeah, patients do want to have a voice. And some of them don't, and that's okay. If they don't, the TeamBirth really centers around the patient. So as much as they need to be a part of that decision making, they may say, yeah, I don't know, you guys tell me what to do. But ensuring that they do have the tools to make that decision is something that we need to ensure we give them to empower our patients and let them feel like they do have that autonomy and they can trust us. Because so many times patients will say, well, I never knew I had a choice. So we want to make sure that we do provide those opportunities and that we are open and transparent and respectful. So we appreciate everyone who is here today, and please feel free to reach out. I know we have the slide. You know how to contact us if you have questions, and if you have commitment letters that you are signing, you can send them to me, and we hope to see you all joining our cohort 3 of TeamBirth. Very exciting. So thank you all. Y'all have a great rest of your afternoon.
hi everyone. Thank you so much for your time.